Cystinuria is an renal disease condition. Look at this picture, shows that stone in urethra, bladder and kidney. Look at this. And medical imaging such as CT findings, MRI and X-ray findings. Look at this. Stones. A detail going on. Introduction. Cystinuria is a genetic disorder that leads to the formation of kidney stones due to abnormal transport of certain amino acids, particularly cystine, in the kidneys. It is one of the most common inherited causes of kidney stones and typically presents in childhood or adolescence. The condition is chronic and lifelong, requiring continuous management. Cystinuria is a hereditary autosomal recessive disorder characterized by impaired renal reabsorption of cystine and the basic amino acid lysine, ornithine and arginine, leading to excessive urinary excretion of cystine, which is poorly soluble and leads to recurrent kidney stone formation. Etymology. The term cystinuria comes from the word cystine, a type of amino acid, and the Greek suffix urea meaning urine, referring to the presence of excess cystine in the urine. It reflects the condition's hallmark feature, high urinary excretion of cystine, which leads to stone formation. Epidemiology. Cystinuria affects approximately 1 in 7,000 to 10,000 people worldwide, with higher prevalence in certain populations. Due to genetic factors, it accounts for about 1 to 2 percentage of all kidney stones in adults and up to 6 to 8 percentage in children. Types. Cystinuria is classified based on genetic mutation and amino acid transport defect. 1. Type 1, complete inability to reabsorb cystine, severe form. 2. Type 2 and 3, non-type 1, partial defects, with variable cystine excretion may be milder. Alternatively, it can also be classified by genetic mutations, a type A mutation in SLC3A1 gene, B type B mutation in SLC7A9 gene, C type AB, one mutation from each gene, compound heterozygous causes genetic mutation in either the SLC3A1 or SLC7A9 gene. These genes code for proteins responsible for reabsorbing cystine and dibasic amino acid in the renal tubules and intestinal cells. Risk factors: 1. Family history of cystinuria. 2. Consanguinity, increased risk in populations with interfamily marriages. 3. Dehydration, promotes stone formation. 4. High protein intake, increase cystine load. 5. Low fluid intake. Complications: 1. Recurrent kidney stones. 2. Obstructive uropathy, blockage in urinary tract. 3. Urinary tract infections, UTIs. 4. Chronic kidney disease, CKD, due to repeated obstruction, infection. 5. Hydronephrosis, swelling of kidney. 6. Renal colic, severe flank pain. Pathophysiology. Pathophysiology of cystinuria, step-by-step process. 1. Genetic mutation. Mutations occur in the SLC3A1 or SLC7A9 genes which encode subunits of a transporter protein responsible for reabsorbing certain amino acids in the kidneys and intestines. 2. Defective amino acid transporter. The mutated genes leads to defective or absent transporter in the proximal renal tubules, particularly affecting the reabsorption of dibasic amino acids, cystine, lysine, arginine, and ornithine. 3. Increased urinary excretion of cystine due to impaired reabsorption. Cystine is excreted in excess into urine. Unlike the other dibasic amino acids, cystine is poorly soluble in acidic urine. 4. Cystine precipitation. In acidic or concentrated urine, cystine crystallizes and precipitates, forming hexagonal crystals. These crystals can clump together to form kidney stones. Cystine calculi. 5. Stone formation and obstruction. The cystine stone may grow and obstruct parts of the urinary tract, urethras, kidneys, leading to hydronephrosis and renal colic and hematuria. 6. Recurrent stone formation and kidney damage. If unmanaged, the persistent formation of stones and resulting obstructions can lead to recurrent urinary tract infections, inflammations, and eventually chronic kidney diseases due to long-term damage. This step-by-step breakdown illustrates how a genetic mutation leads to a chain of physiological changes culminating in recurrent kidney stones and possible kidney dysfunction. Signs and symptoms. 1. Flank pain or renal colic due to stones. 2. Hematuria, blood in urine. 3. Recurrent UTIs. 4. Nausea, vomiting. 5. Urinary obstruction symptoms, example, reduced urine output frequently. 6. Passage of stones in urine. 7. Painful urination. Diagnosis. 1. Urine analysis shows hexagonal crystalline crystals. 2. Cyanide. Nitrobrucide test. Detect excess cystine in urine. 3. 24 hours urine collection quantifies cystine excretion. 4. Imaging, ultrasound, CT scan, X-ray, MRI detect kidney, urethral stones. 5. Genetic testing identifies mutations in SLC3A1 or SLC7A9 genes. 6. Stone analysis confirms cystine composition. Nursing diagnosis. 1. Acute pain related to kidney stone passage. 2. Impaired urinary elimination related to obstruction. 3. Risk for infection related to urinary tract obstruction. 4. Kidney deficit related to disease process and management. 5. Risk for fluid volume deficit related to vomiting or decreased intake. Medical management. 1. High fluid intake. 3 to 4 liters day to dilute urine. 2. Alkalinization of urine using potassium citrate or sodium bicarbonate to increase cystine solubility. 3. Gelating agents such as theopronin, D, penicillamine or captopril to bind cystine and increase solubility. 4. Pain management, NSAIDs or opioids during stone passage. 5. Antibiotics for UTIs. Surgical options: A. Extracorporeal shock wave lithotripsy ESWL. B. Urethroscopy with laser lithotripsy. C. Percutaneous nephrolithotomy PCNL. D. Open surgery is a rare one. Nursing management. 1. Maintain a document fluid intake output. 2. Educate on the importance of hydration. 3. Assess for signs of infection or obstruction. 4. Administer prescribed medications and maintain for side effects. 5. Assist with pain control measures. 6. Provide dietary counseling. Limit sodium and methionine rich foods. Treatment options: 1. Hydration therapy. 2. Urine alkalization. 3. Cystine binding drugs. Example: thiopronine, penicillamine. 4. Dietary changes: low sodium, low animal protein. 5. Stone removal procedures. 6. Long-term monitoring with 24 hours urine test and imaging. Psychosocial medicine. 1. Patient education. Provide clear information about lifelong management. Importance of compliance and recurrence risk. 2. Support groups. Connect with others living with cystinuria to reduce isolation. 3. Stress management. Teach coping techniques for dealing with chronic illness and recurrent pain episodes. 4. School work accommodations facilities. Understanding among teachers, employees for children, adults needing frequent medical care. 5. Psychological counseling address anxiety, depression, or body image concerns related to chronic health issues. Prevention 1. Early diagnosis and genetic counseling for families with known cases. 2. Adequate hydration ensure urine output of at least 2.5 to 3 liters per day. 3. Low sodium diet reduces cystine excretion. 4. Regular monitoring 24 hours urine test and imaging. 5. Urinary alkalization and use of medication to reduce stone risk. In conclusion, cystinuria is a lifelong genetic disorder that leads to the formation of recurrent cystine kidney stones. Though incurable, effective management strategies including hydration, medication, dietary changes, and surgical intervention can significantly improve quality of life. Early diagnosis, consistent follow up, and patient education are vital in preventing complications such as chronic kidney disease. With proper medical and psychosocial support, individuals with cystinuria can lead healthy and productive lives. Thank you. Have a nice day.